Okay, thank you so much, Patricia, again for that terrific talk. And at this point, I'd like to invite both Vinnie and Patty to join me for the Q&A session and the discussion for this session. Okay, so welcome, and actually, I just want to start actually with a question for Patty on your last slide, which was just really striking, where you highlighted the importance of collaboration across the universities globally, and also to share in the training of the worldwide population of scientists and scholars. And so I just wanted to ask, what kinds of actions would you most like to see from universities or individuals from diverse areas to help address this?
Well, all these universities, especially like the top-notch universities in the country, recruit from these areas. But one of the things that they could easily do is set up a way where their postdocs, maybe they can't go, but maybe their postdocs take time to do workshops over there for undergrads or even for high school students. And that kind of experience, and the reason I say that is because that's what I started asking people to do. And so we've done that, and and it's so inspirational to our students. And on top of that, our faculty, because our faculty start to come to these activities, and so then they get more involved in computation. And the problem right now is that it's very hard to hire data scientists and people who are doing this kind of research. They go to industry, right? So it's even like, I can't tell you, we haven't been able to hire somebody for eons that would do this, also because the financial crisis, because all the talent is leaving, right, to these other areas where they can get paid so much better. You're left with a sagging economy, and a non-digital economy, right? And so by sending postdocs that are and then the thing is that the postdocs that we got, one of them was minority serving, was underrepresented. The rest just came along. And I think that the experience made them, like, I know they're going to be incredible professors in the future because they came first teaching like they were teaching from the institution that they came from, which was a completely different population. And so as they've come, they've learned how to tailor their teaching to the audience that they're serving, and yet still be inspiring. And they've also gotten a chance to tell their own stories, and they've talked about imposter syndrome, that a lot of them, it's very funny because people hear imposter syndrome is so much about women and people of color, but we've had people from these top universities that are white males and say, I suffer from imposter syndrome. So it's really powerful for the students, for the students that come, and it's also powerful for our students.
Okay, yeah, thank you, Patty. And I think they're important points for all of us to be thinking about. So thank you. So now I'd like to just turn to both of you, and I think both of you had really inspiring talks that introduce these different schools of thought that all of us in machine learning and health research should be thinking about, and that's with design thinking and the importance of good data from Patty, and then with Vinnie, augmented intelligence and putting people and patients and clinicians first. So we're getting in a number of audience questions from both of you about these, and so go through some of these. So a question for Vinnie first. Can you comment on the role or importance of different aspects like ML explainability and interpretability, workflow standardization, user experience design for a successful implementation?
Yeah, thanks. I mean, I think those are essential and underdeveloped. So, I mean, I think what Patty and I have talked about is ways that data science comes to meet a problem where it's at, right? And whether that's a natural disaster of immense proportions or just high impact problems for real world healthcare delivery that serves, 4 million patients in Northern California or 12 million across the country. That where the rubber hits the road, you have to take the principles and the tools, the powerful technology, but adapt them to the circumstances and the people in need. I think there's still so much to do in model explainability, in model maintenance, in bias, under dissecting and mitigating bias, in data visualization, so that the end users can interpret it in a way that makes sense to them. And so, you know, I think we still have a lot of roles to fill out in, as Patty says, in Puerto Rico, but also elsewhere. You know, I think there's a huge amount of growth and kind of standardization that still needs to be done. And, you know, I think we're going to need a lot of talented folks, hopefully a bunch that are really mission driven, because we're losing a lot of our workforce to, you know, large companies. You know, I have nothing against them except to say that, you know, I think we still need a lot of really mission-driven folks to take on these high-impact problems in healthcares and other communities.
Thanks, Vinnie. Next, a question for Patty. And by the way, for all of these questions, you know, both of you feel free to chime in at any point. So a question for Patty is one of the interesting, extensible, and often ignored data science issues in your talk emphasizes is delineation of assumptions that are being made. And so the question says, I wonder if rather than error bars or something like it, should we show the models with slider bars to allow assumption modifications, or any other thoughts about this?
Well, that would be really, I mean, that would be great, but just putting that in assumes a certain amount of knowledge about statistics, right? A certain amount of knowledge about, you know, I think like even computer science, we were not trained. Like I took a statistics class, but we weren't trained in knowing statistics. I think there needs to be more applied statistics classes for computer scientists, for English majors and history majors. Like it should really be, I've never, I think if given everything that we're going through in society right now, I think it's really, it's so important, because like the people are getting very good at fudging it, right? Scarily good at fudging it. And if having that would be fantastic, but if your users don't understand what it means, it doesn't do anything, you know? So I think basically we need to put more money into training, and maybe even, I mean, I've started thinking we just need to do training that is outside of university for these issues, because the universities right now are kind of so hierarchical and make it so hard to change curriculum. And yeah, we need to have like tech centers for kids teaching statistics, you know, and teaching what it means, what a standard deviation is, what, you know, yeah, just to show, hey, this means, although I give you this percentage, there's really this much leeway because of the you know, the sample size that you use.
Thank you, Patty. And actually, we have another related audience question related to data, and it says it's a general question around design thinking. The person says, I expect that the data discrepancies that are present in COVID death data from different parts of the world that are under-resourced, in addition to data from things like suicides, in general known as a topic with data discrepancy between real and reported numbers. Do you have any ideas of how to approach design thinking for these topics?
Well, I think the great thing about design thinking is that you can have, so these are things, I'm a big advocate for hackathons, datathons, get people together to solve this kind of problem, like make a hackathon or a datathon trying to tackle, how do we tackle this, and bring people aboard to get ideas from a variety of people. And from a variety of industry, like we need industry, and like the thing about hackathons that I love, or datathons, is that it brings a lot of different people together, and building that interdisciplinary, intersectoral communication doesn't happen enough for these big problems. Sorry.
Yeah, no, I totally agree. And actually, following up on that point, you know, I think both of you have mentioned these, you know, design thinking and delivery science and these sorts of skills that researchers in machine learning and healthcare should be educated in. How would I'm thinking of people who are maybe not didn't start off in these fields. Let's say computer scientists trying to learn about delivery science or design thinking, or clinicians as well. I mean, how would you recommend that people could get started in learning about these topics?
Well, I think a lot of it is experiential, is getting on the ground and understanding. I mean, walking through a process. What is, I'll just use my context. What are the EHR inputs, and what are the stressors that are on a clinician during their day that make them choose or ignore pieces of data which are coming through? And understanding that, I think, will help to set some of the context about where tools have their greatest impact. I think the challenge is sometimes that some of our extraordinarily bright computer scientists and data science colleagues, they're wanting to do something really impactful for patients, but without understanding where that specific score, which is highly tailored, will drop into this complex kind of milieu of clinical care, means that it'll often be a beautifully handcrafted and bespoke model, but really may not address the reality of where the greatest point of impact is going to be. So I would strongly encourage them to really walk through, and I think that very much fits with design thinking as well. Empathize and understand what are the pain points. If you're developing a model and you don't yet have a clinical collaborator who's telling you, I'm not sure this is right, well, then you probably need that. Go back to the drawing board, be open to that feedback, because you're probably going to hear a lot of that when you actually try to deploy something.
And I think that one of the things that I loved Vincent's story, because I think that like the fact that we don't have people that are selling cars that know how to teach you how to start or how to stop that's like scary. That's really scary. But the fact is, I'm sure that they don't drive those cars, and they're never taught how to drive those cars. And it's like, I mean, I keep thinking, what about people who are not good at like not good? Like, you really reacted well, you stayed calm, but I'm sure there are going to be people that, like, they're trying it out, they'll just fall asleep, and they'll be like, I trust this, and then they realize I have no idea how to stop it. The other thing I was going to say is that I think one of the gifts of the pandemic is that there's so much good trainings online. Like, people just started doing videos for people. I always refer my students in terms of statistics to Josh Stormer's videos. I also like the Khan Academy has so many topics, and I say, I know it was designed for high school, but really a lot of people could use what they're doing, and they offer it for free. And then there's also like Data Camp is another one that I refer my students to learn how to code a little. You get to do a certain amount for free, and so take advantage of that.
Great, thank you so much, Patty and Vinnie, for these suggestions. And by the way, Vinnie, I'm glad you're okay. Your story with the Tesla is crazy.
Well, yeah, it was actually crazy, but it was an amazing object lesson. I mean, it just highlighted how important the handoffs and the trainings and being able to understand when you're in control and when you're not. And yes, as I said, I almost died, but it taught me so much in that one day.
Yeah. And I just want to point, what I was thinking of is like how it was when electronic health records first came out, right? So like they were so complicated, they were like so unuser friendly that people were dying because of the fact that the nurses couldn't find where, or the physicians, or whoever the medical professional just couldn't find where to go back. They weren't properly trained enough. So
okay, we have another question for Vinnie. How does Kaiser Permanente decide which delivery science projects to develop and or implement?
That's a great question. Probably the number one question whenever I go to visit folks. I mean, what gets prioritized? And I would say that it's actually a very complex process, sometimes maddening for me, But I think the process of working it through those channels, of selling it to stakeholders, I mean, we have to have our stakeholders agree to implement something before we even start designing it, basically. Because otherwise we're going to spend, 6 to 18 months doing some really high quality work. And at the end of it, it's going to land with a thud. So essentially, we present to a bunch of leaders, clinicians, stakeholders. We think about the data. We think about what its projected impact will be at the point in which we intend to place it. We get essentially pre-existing agreements and excitement. And then with that is when we kind of begin the heavy lift of the build. I mean, you have to have some sense, and often it comes from other literature. Like, for example, when I see 3 EHR-based models that reach a certain AUC published in the literature, then I know it's a tractable problem. Like, like other folks have done it. It's not going to be hard. We can draft off of them, or we can use, other, regular machine learning techniques. But yeah, I mean, for us, really, we only want to invest in things which the health system is poised and ready to take up. And so that kind of pre-endorsement and almost pre-agreement is essential for us to deploy successful models.
Great, and we have another question that is related to some of the specific examples you gave of, for example, implementing tools earlier in the workflow to help with triage or risk stratification, such as sepsis or other examples. And the question is, have you done any investigation into equity-related impacts of targeting or implementing these tools earlier in the workflow?
Yeah, I mean, that's such a key question right now, and one that honestly keeps me up at night, because what we've done over the past 5 years is putting models at scale, so they're calculating 50,000, 100,000 times, and building that infrastructure. We've done things like, look at stratified performance across racial ethnic subgroups, and so, have done some of what I would think of as kind of those first level, but not sufficient examinations of whether these models could potentially induce some kind of inequitable care. But we're looking to our colleagues who I think are working hard on coming up with the right tools, because I mean, we all know you can slice the data in 100 ways and you're going to find significant differences, just by chance and just by slicing and dicing. What are the key subgroups that need to be identified? How do we respond to those results? Those are really important questions, and we've been thinking a lot about them. We have a lot more to do, and we're looking for colleagues to work with to really do it well.
If I could add to that, I think one of the things that, remember you asked me the question about what you can do to help the communities like mine in Puerto Rico and other, underserved communities. Like, this is a prime example of where you can do, the postdocs could collect data, you could help, make connections so you can get data sets. Because one of the biggest problems I think in machine learning right now, especially with healthcare, is like the bias in the data. So like establishing research collaborations, not just, hey, we're going to help you and bring education and train you, but also establishing research collaborations to tackle health disparities, I think would be fantastic.
Great, thank you, Patty and Vinnie. Another question for Patty, you gave this really compelling example, I mean, showing the importance of good data and data collection, but also some of the effects of, news and media and social media affecting all of this. And so, just in our current environment, with increasing digitization and social media, I mean, what are the things that you're most concerned about, or what are some things that we should keep in mind going forward in this sort of environment with respect to data collection?
Well, I think one of the things, none of this would have happened in Puerto Rico if that collaboration between universities on the island had not existed. And Raffaele Risari, he's a graduate student of, I mean, he graduated from our university, and we have a collaboration with him, but he's so busy that it's not that close. But to get some researchers that do, like, this is where I see health could be such a great way to create those collaborations, because in the end, it really was an epidemiologist who noticed and said, hey, we need to do something. And then she went to the data scientists, right? And so health professionals that go down there, if they do, because I've also seen the other side of health, where they come and they develop a prototype and it's running really well in Puerto Rico, and then they take it and because they charge a fee that is way too expensive and they can't pay, right? So why not develop a collaboration where you can possibly develop a prototype, but you stay there, you collect data, you find other ways to collaborate so that you can make the world a better place. I mean, it just, if you want better machine learning algorithms, we have to get more diverse data sets. And so there's something where you start doing that kind of health disparity research, and it would make such a difference. The other thing that I didn't mention was, like, the scarcity of water started causing, I can't remember the name of the disease, but people were dying from a water disease in Puerto Rico because a certain bacteria was showing up. Like, and that again was able to be tackled because of collaborations in the health sciences, in environmental science, actually, because collaboration. So these collaborations to these, I think a lot of times, I think the big universities come to our universities and basically, let's take the cream of the crop. That has changed with ours because they see what we're going through. But what we're going through, it's a macrocosm for what's happening through the entire, I think it's happening everywhere. Like, I work on a commission for K through 12 where we have 22 states, and it's happening across the middle of the center of the nation right now. They're going through these crises too, as a result of the digital economy going up. And so they're losing, like, we've been having people coming and buying land, and prices go up because they're buying at higher prices, food goes up, everything goes up, but nobody's understanding and doing that. And that's happening. Actually, I saw an article the other day that it's happening in Montana. And I'm like, if it's happening in Montana, it's happening everywhere, so.
Great, thank you, Patty. So going back to a question for Vinnie, what is the envisioned workflow for the pre-hospital sepsis model? And in our conversations with sepsis clinicians, we've often heard that predictions made before 24 hours of a sepsis event are difficult to act on. Are there existing therapies that you're using in pre-hospital sepsis, or as part of the project to drive discovery of new pre-hospital therapies?
Yeah, that's great. I'll touch on it briefly. I mean, I think COVID has shown us that there's an entire pre-hospital aspect to care. There is triage, there's, potential treatments, rare, but, monoclonal antibodies for high-risk patients. There's wearables, there's diagnostic tests, there's telephonic or video communication. So I think that there is an entire aspect of care that could be enhanced significantly. Now, I think we've done a lot of the epidemiologic research just over these past couple of years to understand that the timing of onset of symptoms prior to a hospitalization for sepsis happens at about 2 to 4 days. So you don't have a big window, and you have a very diffuse signal. But I think COVID has shown us that with the right high impact problem, we can set up kind of diverse channels of patient management and care. I think that the opportunity in the hospital sepsis is very small at this point because of all of the workflow things that have been put in place. And we've seen that the outcomes reduction in the stuff that's coming now, either model driven or other workflows, is usually quite small. It's very, very modest. And so, continuing to invest immensely in that without a new specific gold standard biochemical test or a novel therapeutic, that's targeted to the right subgroup, may not actually produce a lot of outcomes benefit. That's a hypothesis, but a reading of the literature.
Okay, thank you, Vinnie. And we are essentially out of time. It's hard to get through with lots of questions. We couldn't get through everything. Maybe if I'll just end on one last question, if you could both, for both of you, if you can just quickly share your thoughts on this. This is kind of a two-part question, so you can answer any parts of this. How do you distinguish between problems well suited for machine learning versus ones that wouldn't be? And how do you deal with feedback loops from your deployed model, changing data going forward and making it hard to retrain?
How do you deal with, okay, the first part was, how do you deal with?
How do you distinguish between problems well suited for machine learning versus ones that wouldn't be?
Okay, so let's start. I'll start with that. Like stuff for machine learning is, I mean, obviously a lot of the classification, you want to focus more than anything on classification there, but you have to have labeled data. So that's an issue. So that's basically like, if I'm going to do that, I need to, well, you don't have to, but the unsupervised learning has a lot left to do. So right now we really have to focus mostly on machine learning. I mean, supervised learning, and you know, deep learning is an example of that. And as far as feedback loops, that's really complex. And honestly, sometimes we don't understand the feedbacks, right? I mean, I think getting to the point where we're doing more of the causal, what is that called? Causal, understanding what the causes are of our features is probably more important than focusing so much on the feedback right now. I really think that we need to start figuring out what features are having what kind of weight on the output that we do.
I would say to the first problem, what's a good problem for machine learning? Anything where the contribution from any single predictor is relatively small right now, but when you put them together, you know, it magnifies something that's challenging for a clinician to interpret. I think there's also kind of the considerations of, is this tool a safety net, you know, underneath clinician decisions, or is it meant to actually drive clinician decisions? Something about the push and pull of how the alert is intended to into workflow. And then retraining models, another area that we need a lot of work in. I think there's still a lot of methodology to be developed. I would say with our first version 1 models, we've seen some really nice results. We are now entering into version 2, which is taking causal inference, looking at patients who benefited from the model the first time around, and now refining and targeting our models with 2 models, you know, back to back essentially. But there's still so much to do there that it's still pretty early stages.
Okay, great. Thank you so much again, Vinnie and Patty, for joining us today. With that, I'll hand it over back to Clara.
Great. Thank you. Thank you everyone for attending.